First of all, I'd like to say thank you guys all for coming today. You all know me, I'm Christina. I've been working on my bachelor's degree, and part of my bachelor's project is to do a project, um, and I chose to do my project on perioperative education and decreasing patient anxiety. Patients may benefit from preoperative education program. Um, Education helps the patient feel more involved in their perioperative care. It gives them a better understanding of the perioperative process. It helps to decrease perioperative anxiety, and it can improve patient outcomes and satisfaction. Through a Cochrane review, it was found that almost a quarter of patients experienced high levels of anxiety during the perioperative period. Anxiety leads to poor coping skills, increased experience in pain, and a decreased ability to follow instructions. Educational interventions can reduce perioperative anxiety by giving the patient information about what will happen to them when they're in the hospital. Information should be presented in a clear and easy format, and it should be in written formats because verbal formats can't be retained. I did a literature review on education and anxiety. In this study that was conducted by Bisbee, Burasek, Grubbs, Johnson, and Rosatow, it was completed in a 794-bed healthcare system. The patients that were studied were undergoing prostatectomy. They were given a 90-minute preoperative class with patient appointment guide. They did an anonymous survey after the preoperative class, and it was collected quarterly. 196 out of 209 patients responded that they felt the class would help. 191 out of 209 patients responded they felt less anxious or less nervous and better prepared for surgery after the class. Chai Chan, Medazao, Sadatai, all these people did a study in hospitals in Iran and Tehran. They studied 100 laparoscopic cholecystectomy patients between the ages of 18 and 60. Those patients were educated about operating room environment and the surgery team, the anesthesia process, benefits of laparoscopic surgery versus open surgery, as well as postoperative care from the recovery room up to patient discharge. They reviewed patient medical records followed by a face-to-face interview. The interview included a Spielberger state trait anxiety inventory to survey the patients, and that survey showed a decrease in anxiety when the patients received preoperative education. Another study by Castlebeck, DeHaan, and Wolf. They completed 13. We reviewed 13 articles. Those articles included surgical patients that investigated the effect of interventions regarding active involvement of patients, potentially with the help of healthcare professionals, where outcome had to be clearly related to safety. They investigated the effect of education interventions in a structured manner prior to surgery. Descriptive characteristics and type of surgery was the type of data that was collected. 6 of those articles show significant results in decreasing anxiety or improving surgical outcomes. 4 did not show any significant results, and 3 did not show any results at all. This study was completed by Bina, McClellan, and Wonderly in an outpatient setting on patients scheduled for pre-admission testing and oculoplastic surgery. An additional appointment with a registered nurse or a physician's assistant where preoperative instructions, preparation, and issues based on physical, emotional, and social needs of the patient were discussed in the appointment. Baseline characteristics and outcomes were compared. There weren't really any significant differences in this study. Engström, Forsberg, and Reichman completed another study in a general county hospital in Sweden on 2 separate postoperative units. A consecutive sample of patients were hospitalized at 2 general surgical wards and orthopedic wards were studied. They surveyed the patients to identify the perception of the care they received during the procedure and the hospital stay. A questionnaire at the hospital between 1 and 4 days after surgery was given to each patient. 88.3% of the patients rated it important to receive good information about surgery and anesthesia. 80.5% of the patients rated it important to receive good information about what to expect in the operating room, and 72.9% of the patients rated it important to receive information about the stay in the post-anesthesia recovery unit. So after I reviewed all of the literature, I decided to base my study on patients scheduled for outpatient surgical procedures, and I decided to compare preoperative education on the perioperative procedure and anesthesia process to not having any education. And my hopes will that study will show a decreased incidence of anxiety prior to entering the operating room. And to measure that, I would like to use the Spielberger State Crate Anxiety Inventory. The theoretical framework that I used was Newman System Model. Newman System Model is a primary, secondary, and tertiary nursing interventions. The primary prevention is applied during the patient assessment. The possible or actual risk factors are identified and minimized. In the secondary prevention, it relates to patient symptoms following the reaction to the stressors. Interventions are prioritized and treatments are applied to reduce patient symptoms. And in the tertiary prevention, it's applied after secondary prevention has taken place. Maintenance factors are identified and the patient is cycled back towards primary prevention. That can be used in my study because Newman's system model can be applied when educating patients preoperatively to reduce their anxiety. Patient assessment is performed during the preoperative visit, and risk factors are identified. To keep the client system stable, goals may be set between the nurse and the patient. The lines of defense and resistance may be strengthened by creating a plan with the patient. Primary interventions are applied during the preoperative education, and any risk factors identified during the perioperative period may be addressed with secondary prevention. When the patient is in the post-anesthesia recovery unit, tertiary prevention can be applied, and the patient may be able to cycle back toward primary prevention at this time. The proposed project would be conducted in a rural access community hospital. The intended audience of the experiment would be patients in the ambulatory surgery department. The project would be a qualitative study, which means that gathering data on human behavior so that we can understand why and how decisions are made. And it would be a randomized controlled trial, so the subjects are randomized to a treatment proposed project would use a pre-test, post-test design. The Spielberger State Trait Anxiety Inventory would be completed prior to admission and also completed prior to entering the operating room. Every patient scheduled for a procedure would be assigned to either the control group or the experimental group during the year randomly. The sampling would be consecutive. Participants would be assigned to either the control group or the experimental group randomly, and those groups would be divided equally. The proposed project would be approximately a year, just because of the amount of patients that we see. I think that would be enough data. The collected data would be evaluated on a quarterly basis. Each participant would be provided with the information on the proposed project. After evaluating the information, participants would decide if they would like to participate in the experiment. Informed consent would be obtained before participation. Consent to participate in the project would be on a voluntary basis. Participation in the experiment would be kept confidential, and identity of the participants would not be released. So the instrument that I propose to use for the data collection is the Spielberger State Trait Anxiety Inventory. It is the self-report questionnaire measuring the presence of anxiety. It measures the presence of current symptoms of anxiety using two different subscales. The first subscale is the state of anxiety, and it evaluates the current state. There are 20 questions that measure subjective feelings of apprehension, tension, nervousness, worry, and activation of the autonomic nervous system. On the second page, you can see the second part of the questionnaire, and that's the trait anxiety scale. It evaluates relatively stable aspects of the anxiety proneness. These questions, which are 20, measure general states of calmness, confidence, and security. The responses are given in a value from 1 to 4, which makes the ranges of the scores of each subtest between 20 and 80. The higher the score, the greater the anxiety. The test-retest reliability was measured separately for the S anxiety scale and the T anxiety scale. S anxiety scale measures transient states, so the reliability ranged from 0.31 to 0.861 to 2 weeks apart. The reliability for the T anxiety scale ranged from 0.86 to 0.95. To measure the content validity, the STI was compared to the Taylor Manifest Anxiety Scale and the Cottrell and Schreier's Anxiety Scale Questionnaire. The correlations between the STI and these two measures were 0.73 and 0.85. Construct validity of the STI was somewhat limited in discriminating anxiety between depression. The research study would use a t-test for pair groups to test the differences in the two groups. A t-test is a parametric test for testing differences in two group means. It can be done in different ways for this project because the project compares anxiety before education to anxiety after education. And it also compares groups that have been educated and groups that have not been educated. I feel patients who enter the operating room have a risk of increased anxiety. And increased anxiety has the potential to increase the patient's experience in pain perception, impair coping skills, and decrease the patient's ability to follow simple instructions. By educating the patient in the perioperative process, the potential to decrease anxiety prior to entering the OR may improve. Researching the effect of educating the patient preoperatively on perioperative anxiety will prove if education is effective. The proposed project is necessary to prove if education is beneficial for surgical patients. By educating the patient on the perioperative process, the potential to decrease anxiety prior to entering the OR may improve. Researching the effect of educating the patient preoperatively on perioperative anxiety will prove if education is effective. The proposed project is necessary to prove if education is beneficial for surgery patients. And those are all my references. And thank you guys so much for taking the time. I know that you learned a lot today. Any questions? Anybody? Pam doesn't even have anything to say. I could. I absolutely could. It's something that easily could be done here. I don't have to for the class. I just had to propose a study. I didn't learn so much about what I would educate them on, but I learned a lot about how to do the education and how to do the study. So it was very beneficial. The next step for us, I think, is to learn what we need to educate our patients on and find that education. And not just with us, but I think that the offices need that as well. It's really, that's kind of where it starts. I do think it's much better for new surgeons. I think that they educate well. Anything else? Anybody? You're free.